This question says, as the hospitals revert back to more normal working and more clinics reopen, how are CLL patients going to be protected during treatment and getting the necessary ongoing blood tests?
Mhm. So that's a really good question. I think the way we've protected patients generally, and our patients with CLL as well, is first of all clean areas. So trying to keep the risk of COVID from where vulnerable patients are, and we've certainly largely successfully done that. The staff, and you'll see that those of you who go to the clinics are wearing masks, and we've been wearing gloves and using shielding. We always obviously washed our hands before, but they're doing being much more observant over masks and gloves, distancing within the department. So we've at the moment we're able to have less patients coming, so therefore we can spread them out by time as well as by distance, and isolate them in rooms. And so we've been trying as much as possible, but naturally as we get more back to normal, which I think will happen, that will be more of a challenge for us. We've avoided bringing patients into a high risk area. So we've, as well as patients being anxious about coming to hospital, largely, not everyone, but largely, we've also been anxious about bringing them back. So we won't bring them back unless we feel it's necessary. There is, of course, a risk that if we don't do blood tests and we don't assess patients, that the disease can progress, and there's a dangers to that. So we're sort of treading a tightrope, I think.
Yeah, thank you very much. The next question is, if I have a weak immune system, does that mean that I'm more likely to have a real problem if I catch COVID-19? I think you've probably answered that one, but the cytokine storm is the question that's I think mainly unanswered at the moment.
Yeah, so I think what we see with COVID is that there are two parts to this infection. The first part is the actual infection itself, and that can be trivial in terms of its effect, and in some CLL patients can be trivial as well. Loss of smell, or even probably asymptomatic, and that's been the biggest problem. That patients who are asymptomatic can be contagious, and that's why we have to do the social distancing. Two, obviously, severe respiratory infection, and then there's been a second wave, which is cytokine or an immune phenomenon that we're seeing with some patients that leads to this syndrome where patients go into ventilators and have what would have been called a sort of an adult respiratory distress syndrome, we used to call it, and that is something we've seen with other infections in the past, but this is a characteristic of this particular infection. Theoretically, you could have less cytokine storm and less immune response in a patient who's got CLLs on treatment. But having said that, in therapies, some therapies we've given, we've seen the immune system being overactive in CLL. So it's not, the immune system is a very complicated beast, and some of it can be weakened and later have infections, where other bits can make you more autoimmune. So we get people with anemia and other autoimmune problems where the immune system is attacking itself. So I don't think it's as simple as saying, I've got CLL, my immune system's down, I therefore won't have the secondary effects. And we've certainly seen a number of patients who have been unwell with CLL at various stages. So it's an interesting theory, but there's no, that I know of, real science behind that.
Thank you. It's a very complicated situation, isn't it? And it's quite difficult to know exactly what any particular answer is going to be. A very simple question now. Again, it might be difficult to answer. Will I ever be able to, will it ever be safe for CLL patients to come out of shielding whilst there are still cases of COVID-19 occurring?
Yes, there's two elements that will there be still cases of COVID-19 and is it safe? So there's risk to all of us, isn't it? We can all get infections. We can all get risk. There's even people who haven't got CLL have a risk of infections, and so it's about getting a proportionate sort of risk and I think Paul said, making a risk assessment individually. As the incidence prevalence in the society goes down, the risk of coming out is less. And if you take the precautions that we know are effective, hand washing, distancing, and those sorts of things, then the risk becomes negligible if there's less disease of the disease in society. I think, and I have to keep reminding you that I'm an optimist. I think that this virus will disappear. The natural history of coronaviruses over the years is they disappear. They're not necessarily like the flu. So SARS and MERS were less infectious, but they were coronaviruses that didn't come back. And even without a vaccine, there's a chance that'll happen with a vaccine. That certainly should happen. So I think we're in a time where, at the moment, the prevalence is still around, but it's certainly going down. And I would anticipate in the next 2 or 3 months it will go down to much lower levels, as long as the general relaxation of society doesn't have an impact, which it doesn't seem to in other places. So hopefully that wouldn't happen. And then the risk becomes less. And so it's a matter of balancing that. I think the virus will probably disappear in the end, one way or the other. But this year is going to be a bit of it's been a bit of a washout so far from our point of view.
Thank you, Peter. A question here from someone who says, can CLL patients who are on a trial have had suspected COVID get an antibody test? So in other words, is there any sort of preferential treatment for patients who are on a trial, perhaps, to test?
We're talking about trialing actually some of the testing in our CLL patients, and so just to talk about testing generally. So effectively, we have 2 types of tests. We have the test that detect the virus, which are throat swabs, so we can do it on blood, and we do it on bone marrow, we do whatever we want to do it on. But they'll tell you if you have an infection at the moment and if you might be infectious. And then you have the serology tests, which are we're testing your antibodies against the virus. So has your immune system experienced the virus and reacted to it? Okay, so in terms of the antigen test, the PCR, the throat testing, that isn't 100%. So we've seen, and it varies between 50 and 75% of individuals with COVID have a positive test. So having a positive test is pretty, there aren't many false positives, but if having a negative test doesn't necessarily exclude it, because you might not be in your throat, it might be in your lungs or somewhere else. So we usually would test patients a couple of times if they're admitted. Every patient admitted to hospital now, regardless of whether they come in, gets tested. So we can learn about the prevalence of the virus. Also, some patients may not, you excrete the virus for a period of time, a week, maybe up to some people up to 2 weeks. What we're seeing in some of our immune compromised patients, that can go on for longer. And so we are looking at that as well. How long will we secrete the virus, even when you get better from it, is important. And then the serology tests, the first thing we've been waiting for is a reliable test. So a test that gives you a positive result but is incorrect, but is wrong, is almost worse than no test at all. And so the first thing we have to do is get a reliable test. We have lots of different serology tests against viruses, and it's not difficult to develop a test, and they've been developed. So we're now getting tests which have been kite marked, have been given the official rubber stamp, if you like, this test works. The promise from a serology test actually is that we may end up with almost like a pregnancy test, self-do pregnancy test, because the firm that makes those is making antibody tests as well for COVID, and actually they'll be very cheap. And so I think it's likely they will become more widely available. And we've talked in the UK group, CLL group, about doing some studies using those tests to test CLL patients generally, and potentially putting that in the trials and trying to do it more systematically. The other sort of uncertainty, even if you get a reliable test and you have an antibody, does that protect you? And so just because you have an antibody, does that mean you will not get COVID a second time? You'd think that is the case, and probably it should be, but it's possible that the virus mutates and then escapes from that antibody. And so we need that information as well. So serology testing is very important going forward, but I'm afraid we will not know the significance of it entirely for a while until we have a reliable test. So the answer to the question is yes, we probably will use the trial patients to test these sort of antibody serology tests on CLL patients, but we need to understand them better.
Thanks. A lot of unknowns. The next question I'm going to throw at Mark, which has come in, and this says, the issue of stopping food parcels and my local council support said, be careful. They had heard that folks cancelling deliveries and dropping off the vulnerable list. So it would appear that people who have cancelled their deliveries have now been downgraded from being vulnerable. Mark.
Thank you, Brian. Yes, that was the message I was given by my local lead very early on. So I think there was a lot of confusion around. So for the first few weeks, I did get on the vulnerable list very easily. They were very good with my local GP and my specialist in Milton Keynes. I got registered very quickly. I went online and registered for the vulnerable group. But when they phoned me about a week or two in, I said, oh, I don't really need the food parcels anymore. I've managed to get the supermarket. I think I'm getting the supermarket deliveries. That was another challenge. They said, no, they'd heard of people who had gone back in and re-registered, but not needing any food parcel support, had been taken off the vulnerable list. So I continued for another couple of weeks. Now, I was giving them to local church to give to the community, because we did eventually get on the supermarket list. The challenge we had, and it might be symbolic of my age, was it was my wife who was registered with the Morrisons and Sainsbury's of the world. So I didn't register initially with them because she was coming up on their lists of regular deliveries, not my name. I was vulnerable. That changed. I got registered. So I phoned, I went online and deregistered from the food parcels 3 weeks ago, and touch wood, there doesn't seem to have been any impact. So I don't know whether it was a local folk lore or myth, but at the time of the last leukemia care webinar, I said that was the advice I was given. I took the decision to stop the parcels, as I say 3 weeks ago. I'm still getting supermarket deliveries of my medicines, etc.
Thank you, Mark. Thanks very much indeed. We're running out of time now, so I'm going to choose. We've got something like 90 questions on here. We're not going to be able to answer them all, and there are a lot of duplications. This is a very simple one. The question is, will the advice for those on watch and wait be different from other patients?
I don't think so. It would be my take on that. As I said before, we don't have good evidence that watch and wait patients are a lot, less vulnerable than the patients on treatment. It's fair to say, I think the patients who had a lot of treatment or active treatment are likely to be more vulnerable. But what we don't know is whether the watch and wait individuals have how close to normal risk they have. I think it's about individuals making a risk assessment, speaking to your specialists about how vulnerable you are. I mean, and that, as we said before, there is a risk generally, but as the risk of the population goes down, then I think we can't spend the next 2 years in a lockdown like this. I mean, it would really be unhealthy for everyone, even a year. I mean, we're already struggling, I think, even those of us who aren't shielding. And so I think we have to relax it, and we have to do it sensibly. And I think there is an element of, some patients will take no risk at all because that's their nature, and other patients will be prepared to risk assess and take that risk. And I think ask your specialist about it if that's helpful, or your nurse specialist if you have one, and be sensible. I mean, I saw a question about holidays, and just come through. I think I would be cautious about holidays at the moment because we just don't know what the risks are. But it's changing by the month, by the week, and so I think we just have to keep an eye on that. That's how things.
Thank you, Peter. A couple more questions, I think, before we run out of time. Got one here which says, what's the feeling about unshielding, in other words, coming out of shielding, if we have tested COVID-19 positive and recovered? In other words, does it make any difference if you've had the virus and recovered?
Yeah, so I think my assumption is it would help because you've recovered from it and you probably have some immunity to it. Because many patients don't know if they've had the virus or not because it's really mild symptoms and then isolated and didn't get tested. I think this is one of the challenges we're having now. I think the anxiety of coming out of shielding is a big problem, and so we're safe and we feel safe when we're isolated at home, and I don't have anyone coming into the home, but we have to, we want to revert to more normal life. We want to see our children and grandchildren. We want to do all the things that there's a reason to be here. So I think it's about doing it in two things. I'd say one in a way that you're assessing the risk, and secondly, I'd like to be 2 or 3 weeks behind what's happening in the general population. So when we're now a month from the general relaxation, the first relaxation. So now we can see how that's impacted on the viral risk in the community, and now we can start relaxing our vulnerable patients more. And then 2 weeks time we'll know what the changes 2 weeks ago had. So we're a little bit behind. I'm watching very avidly the viral, so the pattern of the infection here and other countries to see, to try and learn about it. And I think that's what we should be doing and being cautious, but not to the extent where we damage ourselves or where we're waiting for the last viral, there's no virus around in community. I think that would be, for most patients, a dangerous thing to do.
Yeah, think about it. I guess it's all a balance, isn't it? It's often quite difficult to make that balance for many people. Perhaps one last question, which seems to be very simple. Does the absence of a spleen make COVID infection more risky?
So I think the answer to that is we don't know, but probably it won't help. I mean, the spleen is an important part of our immune system. We know from, many of our patients will have had splenectomies, and some people, so will live for many decades without a spleen. Certain infections are certainly more severe in people without a spleen, so-called encapsulated organisms, pneumococcus, those sorts of organisms. I do not know of data specifically with COVID, or even actually with viruses, but not having a spleen can't help, but I don't know it's a massive thing compared to some of the other more severe sort of indications of risk, if you like.
Thank you very much for our panelists, particularly Sir Peter, who I know is extremely busy, for devoting so much time to us. It's really appreciated. And I'm sure everybody found it extremely useful and hopefully enlightening. But thank you very much indeed, and look forward to seeing you all again in the very near future.